ADHD rarely comes in isolation, and other difficulties are often present in the same individual at the same time. So in this video, we are going to cover what are the common comorbidities that we see with ADHD at the different ages, in children, in adolescents, and in adults. What we call comorbidity is the fact that two different diagnoses are present at the same time in the same individual. So for example, a diagnosis of ADHD with a combined diagnosis of depression, for example. So in this video, we are going to focus on the psychiatric comorbidities, and we are not going to talk about the somatic comorbidities. So let's start with children. According to the studies, between 40 and 80% of the children with ADHD have another psychiatric condition. In case of children who have an assessment for ADHD difficulties, this percentage tends to be a little bit higher. So you have seen earlier that ADHD is a neurodevelopmental disorder, and what we see is current and frequent association with other neurodevelopmental disorders. So for example, communication and learning difficulties, motor difficulties such as dyspraxia, or tics such as vocal tics or motor tics, and cognitive difficulties and sometimes intellectual disability. Until 2013, the comorbidity between ADHD and autism spectrum disorder, a disorder that is really characterized by social and communication impairments, was not allowed. So it was not possible to diagnose the two things at the same time. But since 2013 and the DSM-5, this comorbidity is now allowed officially. So this has led to a series of studies to examine this comorbidity in greater detail, and a large study has found that 16% of children with ADHD also meet criteria for an ASD diagnosis. So this is really important in terms of intervention, because it will be important to focus both on social and communicative difficulties and also on attentional problems. So in some children, we see what we call a very complex profile. So for example, when there are several neurodevelopmental disorders that are present in the same times and sometimes associated with also somatic problems. And in those cases, it's very important to try to understand whether we could identify an underlying cause for all these difficulties. And one of the questions that we should ask is whether there would be a genetic condition that is associated with all those different difficulties that we see. So the goal of this video is really not to cover in detail all the genetic syndromes that could lead to this complex profile, including ADHD problems, but there are several of them. So for example, Fragile X or microdeletion 22q11.2 are two examples of those genetic syndromes. There is a very recent paper that came out in 2020 that really covers all these different genetic conditions in detail if you are interested by this topic. But what you should keep in mind is that if there is a suspicion of a genetic condition, there really should be a referral to a medical geneticist who could really dig into this issue and do some genetic analysis in this context. So we have covered that children with ADHD often have other neurodevelopmental disorders, but there are also frequent associations with psychiatric issues. The more frequent are oppositional problems that are present in approximately half of the children with ADHD. And in older children or adolescents, there are also sometimes conduct problems, such as delinquency or problems with the authority, that are present between 20 and 50% of cases. And in particular, the presence of conduct problems tends to worsen the clinical prognosis in those children, so it's very important to tackle them. There are also frequent associations with anxiety problems or mood problems, so between 16 and 40% of cases according to the studies. And there is also a frequent association with obsessive-compulsive disorders, so really rituals and repetition that really interferes with the daily life of the youth. And though OCD diagnosis is present between 6 and 15% of cases. So in adults, there are also very frequent comorbidities. This is also the case in adolescents. So again, according to the studies, between 65 and 89% of cases of adolescents and adults also meet criteria for another disorder. The most frequent are anxiety disorders, which are present in about half of the persons with ADHD, adult persons, and depressive mood, or what we call also dysthymia, when it lasts longer, between 18 and 53% of cases. What is important to realize is sometimes the mood problems are secondary to the ADHD symptoms. So, for example, if there are recurrent failure in the professional setting or in the school setting, this can really lead to low mood or depressive mood, and this can really be seen as a negative consequence of ADHD. So during the clinical assessment, it's important to determine whether the mood problem can really be seen as an independent comorbidity or whether this is more a secondary issue to the ADHD symptoms. Another frequent comorbidity is the use of substance, so nicotine, for example, cannabis, and even cocaine. We consider that this is twice as frequent as in the general population of adults. And probably the association between substance use and ADHD is bidirectional. So there are some symptoms of ADHD, such as impulsivity, that tends to drive the use of substances. And also, in some cases, the use of substance tend to worsen some of the symptoms of ADHD. So, for example, the attentional issues that can be worsened by the substance use. It's also important to take into account that sometimes the use of substance is made as an attempt to self-medicate the symptoms of ADHD themselves, or sometimes also the low mood or the anxiety that is associated with ADHD. So in those cases, this is important. This is an important information in terms of intervention, because it means that the use of substance has some value, and there should be some replacement provided to the use of substances. And finally, other comorbidities that should be considered is the presence of bipolar disorder, when there are really some problems of mood fluctuation with low mood associated with periods of excitation or irritability. We consider that the association between ADHD and bipolar disorders is about 8%. And finally, there is not a lot of research about that, but the presence of comorbid personality disorder, especially borderline personality disorder, antisocial personality disorder, and obsessional personality disorder can be considered as frequent. Some literature suggests that it's up to 30% of cases of adults with ADHD who have a comorbidity with a personality disorder. So when going through this list of comorbidities, one question that could arise is what should be treated first? So one of the first consensus is that the most severe disorder should be treated first, the one that causes most disability in the daily life of the patient. And then that we should proceed in a stepwise manner, so going from the most severe to the least severe disorder. Another recommendation is to treat the primary diagnosis. So we have discussed just before the fact that, for example, depressive symptoms can be a secondary condition of ADHD, and in those cases it should be important to treat ADHD first to see if it increases the mood, and then to treat the residual symptoms if necessary. Another recommendation is that if there is a lot of mood instability or substance use, that those should be stabilized before taking an intervention that is specifically dedicated for ADHD. So if you are interested by this topic of what to treat first, you should be aware that the Canadian guidelines, the CADRA guidelines, have discussed this issue in details in the second chapter of the guidelines. So in this sequence, we have discussed in detail what are the frequent comorbidities of ADHD in children, in adolescents, and in adults, and we have also discussed what should be treated first when there are comorbid disorders.